So an acknowledgement also to Dr. Akbar, who had helped me draft a version of this presentation as well. Thank you, Dr. Akbar. All right, so of course we have funding from HRSA, both for the Bridge program, and also I have some funding for a Career Development Award. I have no conflicts of interest, something I'm very happy to report. And this is where we are in the curriculum, right? This is part of our, we're designing a large interprofessional geriatrics curriculum, of which there are 70 some odd modules we're putting together. This is part of the first group of those modules. And I think I think it's an important one. And these are some acronyms that you might find in our slides. I don't know that they're particularly important for this talk today. Except for HRSA, which is our funder, GWEP, which is our grants program name, the Geriatric Workforce Enhancement Program, and of course Bridge, which is the acronym that we've given our program, and for the 4 M's, which I'm going to talk about in a second. So our learning objectives today, we're hoping that by the end you're going to be able to differentiate between interdisciplinary, multidisciplinary, and interprofessional care, to find the benefits of interprofessional care for older adults, and outline some of the evidence-based models for that care. And just as a reminder, these are the 4 M's, a model of care put forward by the IHI, AHA, CHA, and the John Hartford Foundation, targeting 4 particularly important areas of care quality for older adults: the mobility, what matters, medication, and mentation. And we're going to try to highlight these as we move throughout the talk, because you'll find that almost all of the interprofessional team-based models of care are pretty well focused on these 4 points. These are central to geriatric care. All right, so before we start, I'd like to get everyone's mind back into the field of clinical medicine from psychotherapy and from wherever else we might have been, and think about the teams that you've been a part of. And if you feel comfortable enough, I want you to at least think, but if you feel comfortable enough, type into the chat, what is the worst team experience you've ever had? And we've all had some bad ones, right? And then what's the best team experience you've ever had? And how does your current team environment compare? I hope that we are not the worst team experience you've ever had, but we may well be. You might want to save that for another venue, or if you want to speak up, feel free to raise your hand. What made those things the worst or the best?
We have maybe if I may add a point, maybe one of the worst team experiences might be that you feel like you're not contributing to the team.
That's right. So you didn't know your role, you're not fitting in, or you're not knowing where you fit into that team structure. That can be very demoralizing.
I think one of the awful things is when there are bullies in the group.
Yes. That can be very toxic.
I don't respond well to bullies.
Well, I don't know who does.
Some people use a different approach. They withdraw and get into their own space and don't worry about it.
Or become passive aggressive.
Oh yeah, that's another good crowd.
Right. So we have some folks that like our current team. Thank you for that. Another person is saying that they weren't able to provide feedback to the team leader, even if it would prevent patient care issues. That's a big problem, right? When there's fear of communication and asymmetry in roles, and people haven't been empowered to be assertive in the team, right, when they need to be, that's a big problem.
Worst team experience for me is the person in charge of the department is never wrong.
Yes. Yes. And since I'm wrong all the time,
It's not you.
I know that's not I know that's not true.
That's not you. Yeah.
But yeah, no one is right all the time. That's right. Right. So when we have this when we lead from a place of narcissism, that can be really problematic. And so other people talking about communication problems and being passive aggressive. Can everyone see the chats, or are they just coming to the panelists? I don't know if people are sending it to the whole group. And so other people are saying the best teams are when where we're respected and allowed to share, empowered to communicate. Oops. Another person is saying apathetic leadership. Oh, yeah. Right. And another person is talking about maybe the gunners in the group, people looking out only for themselves and their own career advancement and leaving everyone else behind. And so all of those bad experiences don't comprise anywhere near a good team experience, right? And it behooves all of us to think about what makes a team work and what does that do to healthcare outcomes, especially to our most troubled or our most complicated patients, right? And I would argue that the geriatric patients are those complicated patients. So I'm going to start. I don't know what I did to the formatting of this. I made it wonky. Oh well. To consider for a moment a common, relatively common multi-complex patient. So Mrs. Jackson, presenting to our clinic, looking for her semi-annual checkup. Kindly, very sweet woman, 87 years old, Hispanic of Puerto Rican descent, English and Spanish speaking. She's now retired and unfortunately widowed, living by herself in a 4th floor walk-up apartment in Brooklyn, New York. And so before I go any further, I'm already thinking 4th floor walk-up. Oh no, right? Oh no, widowed, living alone, 4th floor walk-up. And so this is just history, this past history, right? We're not going to go into her integral history, the current update, until a little bit later in the talk. So hypertension, hyperlipidemia, CHF, type 2 diabetes, osteoarthritis, 4th floor walk-up, osteopenia, 2 falls, and mild cognitive impairment. So not dementia, no functional impairment, but has had some cognitive change. No past psych history. Very vehemently denied past psych history. Past surgical history, status post bilateral cataract removal, total knee replacement on the right side. Current meds, kind of standard, but we've crossed into polypharmacy, right? On first glance. Any thoughts, Dr. Prospere, about this med list?
I would be curious to know if some of the other participants consider ginkgo biloba a medication.
I include everything that people report that they're taking on these lists. But yes.
Correct.
It's not a medication, it's a very popular supplement among our patients.
And I think that is one of the reasons why patients may withhold that information, even though that can have significant impact in terms of drug-drug interaction on other medications and how the body responds. So yes, it should be considered, even though it's natural or it's an herb or whatever we want to call it, it should be listed under the category of medication. Or natural supplement, but medication.
Right. So I think in particular, ginkgo interacts with other blood thinners, right?
Yeah.
I think there's an interaction with aspirin.
Correct.
So yeah, we got to know polypharmacy. We're in thinking increased fall risk, right? She's already fallen twice per this history. We're osteoarthritis, 4th floor walk-up, right knee replacement problem.
Yeah.
And multi-complex history, and we are a geriatric clinic, and we're probably operating alone, and I'm already feeling a little overwhelmed by how many things I'm going to have to do for this patient in one session, right?
Yeah.
Social history, born in Puerto Rico, 5 siblings, 4 deceased, married for 60 years, but widowed for the past 4, 3 kids, all in New York City, which sounds good on the surface. Retired nurse, right? So tough. Love my retired nurses. Catholic, attends church, but doesn't go to a senior center. No cigarettes, thankfully, but does drink 2 to 3 glasses of wine per day. No drug use. Any flags on this profile so far from the other history? In chat or otherwise?
I put a couple of things in the chat, but you may be going to get to them. I'm always looking for the bottom line, and who is she coming to see? Why is she coming to see, and what does she want?
Right. So this is standard semi-annual checkup.
Okay.
She wants refills. That's.
And she's coming to the Jerry clinic, or the psych clinic?
We're framing this as geriatrics.
Primary care. Okay. Yep. Thank you.
And the 2 to 3 glasses of wine daily.
Yeah. So we're thinking, and so yeah, so we've crossed over for her, for an older woman, what might be the recommended amount of drinking, and we have a separate lecture on substance use. But it's always worth talking about that, what that means, and what is the when people say glass, they mean different things. Dr. Prospier?
No.
Yeah. Oh, yeah. Yeah.
And do we? I'm sorry. Go ahead, Clivia.
You're muted, Clivia. Clivia, you're muted.
I also want to know more about like her connection with her children. Is it a good one? Are they supportive and things like that?
So that's not clear yet, but
okay.
On the surface, they love her very much, but they are very much, like all New York City dwellers, they're working 2 to 3 jobs to support their own families. And they don't live with mom.
And I know there's a separate lecture on substance. Do we, and just for everyone, do we accept the 2 to 3 drinks per day as 2 to 3?
Absolutely not, right? We need quantity. We need like an actual amount that we're drinking each day. Is it really 3, or is it, I'm saying 2 to 3, but it's 5 to 6?
And that's only for the day. That's not for the night. So that's 2 to 3 per day, not per night.
Yeah, that's true. Actually, that's true. I don't think I framed the question that way.
Oh, man.
I'll never forget the day I learned this lesson in our clinic, when I asked a little old lady how much she had been drinking, and she said 2 beers a day. And I said, okay, what do you mean by beers? And she said 2 40-ounce malt liquors. And I learned that is the most important question to ask. If I drank 2 40-ounce malt liquors, I would be hospitalized, as would most of us. But she was up and moving, and she'd had somebody delivering them to her. It was a whole system. All right, so, and there's a comment in the chat. I want to know if she feels isolated because of her bereavements, and she's not connected to a senior center. So this is a tough lady. That was a tough assessment to make. She didn't initially endorse that she was isolated. She was very connected to her church. She felt, that she was very connected to her, I think, religious community, and that her kids were all working, and she understood that they had to work. She missed her husband. So I think the initial assessment of loneliness probably needed a little more sussing out. I don't know how close we got to that, but that's a good point, right? We know that connectedness is important. Dr. Rahim just emphasized that a whole bunch. And so I don't know that we can fully address this brainstorm because of where we are in the time. But think about the complexity of this woman, her multiple comorbidities, her social milieu, the possible substance milieu, And if you were in your current clinical environment, right? And so that might be for our, NP students, they might be working in a long-term care setting, or they might be working in a primary care setting, or our other students might be working in various primary care settings around downstate where they don't have, the full team that's always available to us in our Alzheimer's center. What do you do, right? And how do you manage that? And what referrals would you need to make for this first case, or for this case? And what would be the ideal model of care for Miss Jackson if you could change the milieu that she's currently in to a different milieu where something else might be available to her? Right, so there's a comment about wanting more assessment first and what her goals of care are, which is absolutely right. We didn't get to the assessment yet. I'm just providing background. And Clivia? You had your hand up.
No, I'm sorry, no.
Oh.
I was just rubbing my hands.
Oh, okay.
Sorry.
I know, we're all getting carpal tunnel from all the computer, right?
Yep.
You have to be careful.
I'm also not sure that this is so unusual a situation.
Well, I think that's kind of the idea, right? This is a lady that we are often meeting in our clinic, and if we take the time to dig into her actual needs, there's a tremendous depth of need that we should be addressing, right? To fully help her meet the complexity of her care needs, as long as it aligns with what she wants, right? What matters most to this patient is paramount to her care. And that's where we maybe run into a little trouble later, because sometimes the healthcare system's idea of what should matter to her doesn't line up squarely with what actually matters to her. And she was a fiercely independent woman, fiercely independent woman, which we, is great, and we don't want to take that away from her. So let me keep the chat open. So I think it's important to conceptualize the care of the geriatric patient in an interprofessional way. Everyone should be involved in an older patient's care, and how you design that system and how you involve different people depends on each person's care needs, and there's different models that have been developed to handle this, and that we're going to talk a little bit about that today. So our patients are complicated. Multiple comorbidities, multiple treatments needed, multiple professionals required, and care quality improves when we involve a multiplicity of professionals to deal with the multi-complexity, right? And so there's different definitions for interprofessional team-based care, or team-based care in medical care, right? So there's multidisciplinary teamwork, which is similar to interprofessional teamwork, but it's across disciplines rather than professions. So like in our instance, the Bridge program, Dr. Taylor is one of our most valued team members and co-directors, right? She's an anthropologist. She's working with us across disciplines. So we're both interprofessional and multidisciplinary. And so within multidisciplinary teamwork, people are sharing info but they're not directly working together to formulate a treatment plan. And that's compared to interdisciplinary teamwork, where it's the same idea, right? So there's multiple disciplines working together, but they are working together to form treatment plans. And then there's interprofessional teams, which is talking about collaborative care across healthcare professionals who are working together with clear roles and shared treatment planning, which is the model we're trying to live in our Alzheimer's Center, right? And trying to teach as part of the Bridge program. And I know that there's a movement towards some newer phrasing for this, which is trans-professional. I don't know if you wanted to elaborate on that quickly.
I'm still trying to get my arms around what actually that means, but it's collaboration squared, I guess. It's really it's what I would have called integrated practice, but there is a definition, so I can look that up and
oh, that's okay.
Send it.
You had brought it up last time, and it popped into my head, so I wanted to give you the chance. Yeah.
I do need to look it up because I was doing something else and I needed to talk about it. So.
Okay. All right. So just to quickly assess how we did with that, I'm going to put up a poll and to see how we did with that. I moved away from the slide to see if I clearly.
That's tough. It's a 50-50 split.
Panelists can't vote.
Oh no, I thought I fixed that. I'm sorry. Give it another couple seconds. All right, I'm seeing from the answers that I need to work on the phrasing of this question. It's important feedback, I think. So I'm going to end the polling and share the results. So what we were going for was E. So you differentiate interprofessional teamwork from multidisciplinary teamwork. Interprofessional teamwork has to do with healthcare professions working together to formulate a treatment plan. So both B and C, right? And that differentiated from multidisciplinary teamwork because there's, it's between whether there's professions participate, different healthcare professions or different disciplines participating together, right? So both B and C were what I was going for, but I think there's some wording improvement to make that a little better. I see my co-panelists nodding, nodding their agreement. So we'll fine tune that. But thank you for your participation. All right. So, and then of course, when you talk about interprofessional teamwork, you have to also talk briefly about interprofessional education, right? Because if you don't train people to practice together, they're never going to practice together. We all tend to practice in models that we're most comfortable with, and those are the models that we trained in. And so interprofessional education is when you're training across healthcare professions within a clinical teamwork environment. And that's what we're doing, right? We're training you at our Alzheimer's Center to work together to improve healthcare outcomes for patients. And so this has been formalized across the nation. There's interprofessional education competencies to make sure that we're adequately designing curriculum to train trainees and build them into the next generation of providers that can operate in these environments. And the government has really been heavily invested in doing this since the 1970s across multiple different iterations of healthcare training grants, starting with the VA in the 1970s to the HRSA programs, the GECs and the GACAs in the 1980s and 90s, through our current geriatric workforce enhancement program, which started back in 2013. We weren't a part of the original cohort, but we joined the GWEP cohort in just now in 2019. And so there are all sorts of examples of interprofessional teamwork that I'm going to run through and give you, I think, a brief overview so that you can think of what has worked in other healthcare settings and how you might apply that to your environment to improve outcomes. And so there's disease-specific team care that has been studied in geriatrics across, heart failure, diabetes, post-stroke, and there's program-specific and site-specific. I'm going to run through interprofessional integrated models of care across 3 different care settings to give you a sense of where the evidence currently is. And so first, we'll start with inpatient models of care. And I want you to think as you're going through this, right, as you're listening to me, why these models are so important in stopping ageism within the healthcare settings, how they are being implemented to improve care, and what you can do to take these models and stop your other providers on your teams from perpetuating ageist care within the healthcare setting that you work. And how are the 4Ms incorporated into these models? How could you build a new model that utilizes the 4Ms as their core in your setting to improve care? And so we'll start with the ACE. This is a very common model of care that's been around for years now. ACE stands for Acute Care of the Elderly, and it's an inpatient model of care. And so what I like most about this model of care, as is exemplified here on this slide, is it takes in a functional older person and it spits out a functional older person, right? And I really want you to push yourself to think about how different that is from the standard inpatient model of care, in which there is an ingrained expectation for an older adult to come into the healthcare system and leave with a higher level of deficit than they arrived with. The whole system is almost predicated on this model, right? We're already thinking from the moment a patient comes into the inpatient, how are they going to need acute inpatient rehab? Are they being deconditioned? And we're not necessarily putting the plan in place to stop that from happening while they're an inpatient. We're thinking about disposition long-term and deficits that they're likely to have. It's a deficit-driven model. And that is a big problem that ACEs are trying to fix, right? So we take a functional older person who has acute illness, possible impairment, maybe not yet, right? They get hospitalized, they're placed in an ACE unit, right? And there is a prehab program in place that is anticipating what is happening for that person, where they're going to be, and negating the negative outcomes of care, right? And this is done in an interprofessional way to improve mood, reduce impairment, decrease iatrogenic risk, and spit out a functional older person. This should be inherent in all of our healthcare settings. Super important. And it's not actually that much more expensive to do than what we're currently doing, because the same players are involved, right? We have these same players already in acute inpatient settings. You just need to reformulate them into this type of team, right? And the outcomes are great. Less disability, shorter length of stay, less likely to be transferred to a SNF, skilled nursing facility, less falls, less restraints, better mobility, reduced 30-day readmissions. Great. Overall cost of care drops. And then the same thing has been applied into what's called MACEs, right? So this is a mobile acute care for the elders program. So you take that same ACE model and you make it mobile. You realize that not every hospital has the space, like downstate, to build its own ACE unit, right? They don't necessarily have the staffing. So you make a team that goes to the patient across the other units of the hospital, standard med-surg units, and the outcomes are just as good. Hospital Elderly Life Program, multifaceted intervention with the goal of reducing delirium, right? So there are protocols targeted at delirium risk, and they take an interprofessional team, which is centered around an elder life nurse specialist, trained volunteers, and the interdisciplinary or interprofessional team. They implement risk factor-based protocols, depending on what each person has going on, to limit the incidence of delirium, and thereby improving healthcare outcomes, morbidity, mortality. Very well studied. Over 200 programs are running the Hospital Elderly Life Program at this point. Delirium goes down, number of episodes go down. No difference in severity or recurrence, but we seem to be able to prevent a little bit more. And it's often implemented with other programs like ACE and NICHE, so you can have this multiplication of effect when you're using multiple models overlaid on each other. And then there's NICHE, right? The Nurses Improving Care for Health System Elders, which is centered on the nursing model of care. So this model uses a geriatric resource nurse that educates other nurses, which then serve as teachers to others, and a clinical resource on geriatric issues. There's a coordinator that organizes the education and modeling of protocols and best practices. Interprofessional team care modeling. And this is targeted on very specific areas of concern in geriatric care where healthcare outcomes drop, cost of care goes up, and reimbursement, quite frankly, from Medicare, Medicaid goes down for healthcare-related infections, et cetera. Things like pain, pressure ulcers, adverse med events, delirium, et cetera. So this is usually implemented in hospitals, long-term care facilities, home healthcare practices. And I want you to think about, as we're going through these models, what are the key ingredients? I usually like to pause and have a little more discussion, but we discussed a bunch and we're running out of time. What are the key ingredients for these models that make them effective in improving outcomes? And as Kathleen Bradby said, who's driving the bus, right? In all of these models, there is a team leader that coordinates with the interprofessional team and ensures communication is in place, ensures education is occurring, ensures that the model of care is adhered to, that and that patient outcomes can be improved. The team leader and the communication are absolutely vital. And frequently that's nursing, actually. Nurses are great at this, vital members of the healthcare team. In a lot of these models, the NP is the leader. And so there's transition of care models, right? We all know that transition of care represents a very high risk moment in the care of any patient, but particularly older adults. And it's at this moment that healthcare outcomes can dramatically change if you don't have a good system in place. So there's the TCM model that uses a team leader, usually an advanced care nurse, to improve discharge transitions, ensure follow-up care is in place, ensure that necessary interventions are in place. They begin early discharge planning with the whole interprofessional team, and they follow up at home for 2 months after discharge to make sure that people are adhering to their treatment, understand what the treatment model is, that we are meeting their person-centered goals, right? What matters to that person. Really, really good stuff. And this, of course, also reduces or improves outcomes. Hospital stays go down, cost of care goes down, and it's more cost effective. The care transition program, similar idea, using a care transition coach, which is also usually an NP. It has 4 main components. They meet at discharge, the NP and the interprofessional team educate on the med, self-management, the creation of a patient-centered record, effective communication with the primary care doc. Like, how do you talk to your primary care doc about what happened? And red flags that identify the worsening of symptoms and how to respond. Central to this is who is helping coordinate all of the care, who is educating, and how is it coordinating with the whole team who's taking care of this person. And they have 2 or more home visits within 30 days of discharge. And again, outcomes are improved, right? So these are the pillars of this model, right? Follow-up, red flags, patient-centered record, and medication self-management. And with this in place, you improve the transition back to home. And there are others, Project Red and Boost, and others still that we're not going to be able to cover today. But these models are vitally important. And then, of course, there's outpatients models of interprofessional care, something that we're very interested in. There's the GEM, Geriatric Evaluation and Management Program, which basically we know that the comprehensive geriatric assessment is the gold standard of geriatric assessments, right? And then, of course, it's more beneficial when performed by an interprofessional team. So the GEM team, comprised of interprofessional team members, works together with a primary care doctor to provide co-management of complex cases. They present intermittently to provide tune-ups of their care, review their meds, review their current care, provide recommendations back to the primary care doc, or longer-term follow-up. And sort of not surprisingly, primary care docs love this, right? They love that extra bit of help to manage their complex patients. And patient outcomes also improve. This is one of my favorite models of care. This is the PACE program. It's the program of all-inclusive care for the elderly. There's a couple around New York. So these are comprehensive primary care for persons 55 and older who are candidates for nursing home placement. So PACE programs receive capitated payments from Medicare and Medicaid, meaning they get paid per head. They get a lump sum of cash per head in their program, per person, And then they use that money in any way that they think that they are within certain strictures to provide comprehensive care for that person. And so they provide everything, right? So they exist as a day health center with all care available to their patients across the spectrum. Primary care, oral health care, mental health care, substance care, podiatric care, et cetera, et cetera. And because they are responsible for their quality of care outcomes and their own cost control, they're very frequently able to cap costs quite effectively, reduce admissions, reduce bad healthcare outcomes, and have money left over for other cool programming for their patients. They can frequently provide food and other nutritional programming that a standard insurance-based payer model will not allow doctors or hospitals to do. Right? We have a hard time with it. We can't provide free food for everybody. We wish we could, but the PACE programs frequently can. So people enrolled in these programs stay in the community longer. They are placed into nursing homes at a lower rate. They have improved rates of hospital stay, readmission, and cost of care, and improved survival. I don't know why we're not doing more of this. And then there's the GRACE, which is a interprofessional model of care targeting low-income elders across 12 domains of their health care, which is comprised of an interprofessional team. Again, there's a support team and a main team, right? So the support team is the NP and the social worker, which works with the whole interprofessional main team. The social worker and NP go out and meet with the patient, conduct a comprehensive assessment, bring it back to the IPT, who then can review all of the data and provide recommendations, treatment planning according to their protocols for the geriatric syndromes. And the support team then coordinates the implementation of that plan. Really effective use of everyone else's time, right? So you can cover more cases with your whole team by using this model. Even with this, though, it's still quite expensive, and even though outcomes improve quite dramatically in high-risk patients, there is a substantial cost to this program. Only about 10% of the costs for GRACE are covered by fee-for-service Medicare. I'm going to skip that. And then there are programs that are meant to also divert patients from the hospital to stay at home, like the hospital at home programs, which target people that are entering the emergency room, would likely have been hospitalized for common infections like CAP or CHF, COPD, et cetera. And then they're moved into their home environment and provided the same level of care just at home, right? Really, really great. And again, it has improved outcomes, right? Decreased length of stay, of course, patient and caregiver satisfaction, delirium goes down, cost of care goes down. And home-based primary care, which is also quite similar. And there are things like impact model, which are very similar in nature to the GRACE model, which has similar improvements in patient outcomes. And there's another impact model, which this is not to be confused with. Impact is related, as we're discussing today, as a primary care model, but there is an impact protocol for targeting depression in older adults as well. Oops. So coming back to our multi-complex case and our interval history. So since last appointment, she's had 2 new ER visits, both for falls, both happened at night, no head injuries, excuse me, and now has a new right wrist fracture. Hypertension. She wasn't able to keep a log in a large part due to the fact that she's a right-handed lady and she wasn't able to write quite as well as she could before. Her current blood pressure is a little up. Her the numbering is weird. CHF, she's sleeping on 2 pillows, still able to walk a block without resting, but only 1 flight of stairs. And as a reminder, she lives on the 4th floor. Diabetes, again, wasn't able to keep a log, finger stick 189. Hemoglobin A1C 8.9. Has not modified her diet, does not want to. Does not want to, loves her food, really into her, the cuisine of her culture. Hyperlipidemia, again, hasn't modified the diet. Osteoporosis, she takes Tylenol multiple times a day for pain, but can't tell us quite how many. Mini mental, 26 out of 30, still in the normal range. No real cognitive-based impairments on the assessment. It really seemed as though her inability to keep logs was more, in fact, due to the right hand fracture. And the alcohol, so she's still drinking three large, like 8 to 12 ounce glasses of wine a day. Doesn't see this as a problem and says, I'm retired. I'm free to do what I want with my life, right? And that's right. That's right. There are, but you have to, that's balanced with our need to provide education onto the potential outcomes of her choices. Dr. Prosper, you had another thing to say.
I'm often reminded that health has to do with the state of complete physical, emotional, and psychological well-being. A lot of times, oftentimes, us, the physician in the medical field, we put a lot of emphasis on the medical component, getting the A1C down to goal and getting the cholesterol down to goal, not taking into consideration what matters to the patient, how the patient feels, and what the patient enjoys, So that psychological and emotional component is very important in terms of defining health, yeah.
Absolutely. Right. So socially, she stopped attending church because she just can't handle the stairs anymore. She can't grip on with her right hand onto the banister as she's going up and down, and this was a big loss to her. Children not visiting due to work, and she really needs them right now, doesn't have a home health aide. And she's losing weight because she loved to cook, and her right wrist is fractured, and she's having a tough time cooking. So now we're more worried about her. And so we have multiple of the 4 M's that we're worried about, right? So mentation, she has MCI, but no real cognition-based deficit. But she's at risk for delirium and other things if she winds up more sick. We know that. Medication, she's still experiencing polypharmacy and not so sure about adherence. And there are potential interactions between her meds and other meds, and also meds and the alcohol. If I miss anything, anyone else jump in on the team, please. Mobility, clear problems, right? And what matters? And what matters, I guess she knows what matters to her, and where we're starting to have a conflict between what we think should matter and what she says matters. And that's perfectly okay, but we got to work it through. And you have to, and so this is where we, even as geriatricians, we struggle, right? It is ageist to assume what will happen next with this lady's care, right? And it is ageist for me to be thinking, which I am thinking, I know it's not right, that she needs a higher level of care, and I should push for that. It has to be carefully balanced with her needs and her wants. It's tough. And Dr. Prosper, you look like you have other thoughts to express about that point.
Well, I'm pondering the definition of ageism, what it is, because it's discrimination. But we do know that certain health outcomes are linked to certain conditions, right? Certain behaviors. So, for example, uncontrolled diabetes, she's at risk for mini strokes or even major strokes. So she's at risk for multi-infarct dementia and other conditions. She's at risk for falls. So,
absolutely.
It's what's associated with her comorbidities and her lifestyle. So is it ageist? I'm just pondering. Is it, I'm pondering that.
So I think the ageism that I'm referencing comes into the fact that I want to assume what needs to happen next without getting her full input. And I think her input in this case is that she wants to stay home. That's where she and her husband lived. She's been in that apartment for many years. That's where her kids were raised. It doesn't matter to her that it's on the 4th floor because that's where her memories are, right? And I think And when you work in an interprofessional setting, I'd like to think that there's a way to work this through as a team. I could see Clivia nodding that there's a way to manage this so that we can have the best of both worlds, at least, you know, as much as possible. Or we can give her, yeah.
I was going to say, what I would do is I would sit down and I'd make a list of all of the things that I think that she might do. Like one of the things for her wine consumption, one of the things that might be helpful is to have an ounce of wine and 4 ounces of club soda or diet tonic that have no calories in it with a lot of ice, and that's a good tasting drink. Somebody also suggested that one thing that people, when they like to have a cocktail, you can do like any kind of soda, put a little bit of some liquor in it and then a little bit of bitters, and it tastes like a drink. But to make a list and say, okay, here's some ideas that I have for things that might be helpful. And then to work with her about which ones you want to pick and choose, and start with little things, one thing at a time. And I just realized it's almost 5 o'clock and I have another event in a few minutes, but this is great. Got me thinking.
I think that's the big point of this talk, is to think, right? And how we could all work together. And it's clear, even I enjoy this model of having the presentation wherever, especially all the panelists are interacting, because it emphasizes the point, right? None of us is going to have the whole picture. We all have to work together to improve the outcome. And I'm never going to think of everything that Shirley thinks of. Dr. George, yeah.
I would also,
that may be a good thing, but
I would also see if she will give permission to maybe contact like one or more of her children to see, you know, if we can sort of have a discussion. You don't think so, Shirley?
I'm sort of role playing. I'm putting myself in her role, and it's like she wants to be independent, you know. And one of the things, I mean, I do this with people all the time. I say, you know, tell me about, you know, about how you're feeling. You know, would you want to see your kids more? What's your relationship with them like?
But that's what I said. Only
and she may say, you know, they're a pain in the ass. I don't want to talk to them. And
that's okay, but at least we ask the question. I mean, I wouldn't do it without her consent. Absolutely.
Yeah.
Absolutely.
Yeah. I'd be, if you told me I need to talk to your family, I'd say, don't, they're crazy. Leave them out of it.
But that's important. That's important. You know, not everyone's family can be the supportive, you know, holding environment that you need.
There's probably fewer families that can be supportive, especially these days, than are. So what else can we do for her?
Yeah. So in this case, I think the family was not, you know, a pain in the tush. I think it had more to do with them being too engaged with their own lives and not wanting to sacrifice that to take care of mom.
Mm-hmm.
So.
And it's also sad for her because all of her siblings have passed away. So it's not that she can, you know, spend time with any of them or things like that.
Yeah. This is tough, and it emphasizes too some of the points that Dr. Rahim made about the losses that people work through in later life and what it does to their mental state. And actually, it looks like Dr. Rahim is still on, and he noted that she might like the altered reality that alcohol gives her, especially that amount of alcohol. Mm-hmm. Leaves her someplace else at the end of the day. And I think that's right. I think she did need that. So is this patient falling through the cracks of the healthcare system, or is this, how do we frame thinking about this patient, and what should we as a team do first, right? And that's what we were all just kind of discussing. What's the next step? And what model of care might best serve this patient? We're already at 5:02, but if anyone wants to chat in any discussion on these topics, I'm happy to talk about it further.
I think the first thing is what matters to her. What are her healthcare goals?
Yes, that's the question that's missing from this brainstorm.
Right.
So her healthcare goal is autonomy, to put it in one word.
Right.
She wants to be home
Okay.
at almost any cost.
And I think to some degree that's embedded in the first question. Why is this patient falling through the cracks of health? Is she falling through the cracks? What do we mean by falling through the cracks? Because her preference is different than what our goals are. Then we can say she's falling through the cracks. But if we're tailoring things to her preferences, then she may not be falling through the cracks.
No.
So I think when I originally wrote this question, I was thinking more along the lines of this is a patient that's coming to the doctor, has had falls, is drinking alcohol, is having more falls, has had a fracture. And it feels like we were missing something, I guess. And something that we seem to be all getting, as we're sitting here talking, we're getting it, right? So she's not falling through the cracks of us right now, but it seems like her current family and physician or care milieu is not fully meeting her needs, I guess, in the doctor frame. In her frame, she's happy to be at home.
Dr. Reinhardt, is she
Yeah.
drinking alone or is she drinking with friends in her apartment or something like that?
All alone.
Oh,
Yeah. All alone. Yeah. Yeah. Well, I could go off on a tangent with that, but yes, mostly alone.
I had a patient like that. She really did not know how much she was drinking.
Yeah.
Report from the daughter.
And it becomes normalized too, because it's such a part of everyday life that it stops being. We don't think of it as a problem. People don't think of it as a problem. All right. So it's clear that she is benefiting from interprofessional interaction even amongst us, right? And that's the idea. And so you have to think, how do I implement the same kind of modeling into my healthcare setting, right? So the first step is knowing the available models. And if you're really going to move in this direction, you have to be ready to generate a business plan, a clinic protocol. You got to train your team. And then you got to track outcomes to prove that you're doing what you said you were going to do. And you got to keep improving, because you're going to cost a lot of money when you do this. So you have to prove to your hospital that you are worth the money they're putting into you. And I think we've proved that. But when you start a new program, it's really important to do so. And you have to be mindful of the elements of interprofessional team practice, right? Like we talked about at that very beginning. These elements that you guys all brought up were absent from bad teams or present with good teams are vital to your success. We have to be responsible, accountable, coordinate, communicate, cooperative, assert when we need to assert, and be willing to, within the bounds of our professional roles, be autonomous and have mutual trust and respect that your care team members are going to get the job done, right? Really important, right? And know what team training is available. I would recommend Team Steps because it's the most current and active and freely available from the government. And know the barriers, right? We're trying to break down these barriers in our clinic, right? Limited training of the current healthcare workforce is a major barrier. If you have never practiced in an interprofessional setting, you're not going to do it. We have to break down the silos and do it, right? We have to do it in education and we have to do it in practice. And of course, there's the systems and cost and human resource issues. By human resource, I mean the availability of geriatricians. There's just not that many. The healthcare workforce is not trained enough in this as far as having geriatricians goes. And think about your current workplace and what the barriers specific to you would be, and how could you overcome those barriers? And I promise you, as we've all discovered, that it really makes things a lot more fun. My satisfaction is dramatically improved by working with Dr. Prosper, Clivia, Carlene, Eating, Victoria, Cyan, whoever else I'm leaving out, Dr. Taylor, everybody. Patient satisfaction is improved, quality of health is improved, pain goes down, falls go down, QOL goes up, independence goes up, depression goes down, everything gets better. Why are we not doing this, right? And so back to Mrs. Jackson. So unfortunately, Mrs. Jackson, it took one more fall for things to really change. She fell again in her home alone, and fractured her left wrist. Fortunately, she was able to still dial the phone with her right hand, and she did get help. She was admitted to the hospital. She had to have detox. It was alcohol related, the fall. And she was referred to outpatient substance treatment. And we had to call APS at this point because we really couldn't get the kids into the house to deal with what was happening. And I don't think that they were mean-spirited. They really just couldn't conceptualize the decline of their mom and how they would have to change their own life. It was, New York is tough. I don't know what else to say. But we got her, instead of, heading to a nursing home, we got her into a pilot program, a nursing home diversion program, which provided her with 24-hour home health aide care, which is a relative rarity these days. So she was able to recover and stay in her home. We respected her autonomy and what mattered to her, right? And we got what we needed for her to be safe, right? We got her a little better too. And she's still at home. I feel good about this case. So congrats, you guys are now experts in interprofessional care of older adults. That was a whirlwind tour, and though I started late, I will say that I finished still in about an hour. Are there any last questions, comments, concerns? I had a couple other polls that I didn't use because I was moving too quick.